A premature neonate presents with abdominal distension, feeding intolerance, and septic shock on day 10 of life. I am showing you an initial abdominal radiograph. Describe the findings.
Okay, looking at the images, the abdominal radiograph demonstrates a cord clamp, confirming a neonate in the first few days of life. There is marked generalized gaseous distension of the bowel loops. A bubbly, granular lucency is visible within the bowel wall, representing pneumatosis intestinalis. Additionally, there is a large pneumoperitoneum, evidenced by free air outlining the liver margin and diaphragm. No branching gas is seen in the portal veins. These findings of pneumatosis intestinalis and free air are diagnostic of necrotizing enterocolitis with bowel perforation.
What are the key pathophysiology steps in necrotizing enterocolitis, and what are its primary risk factors?
The primary risk factor is prematurity, which accounts for 80% of cases, typically presenting in the first 2 weeks of life. The pathophysiology is multifactorial, initiated by mucosal injury from perinatal stress, hypoxia or hypotension, which triggers bowel ischemia. Enteral feeding then provides a substrate for gas-producing bacteria to colonize the damaged mucosa, leading to mucosal necrosis. This allows bacterial gas to dissect into the submucosa and subserosa, appearing as pneumatosis intestinalis, which can progress to full-thickness necrosis, perforation, and portal venous gas tracking.
Contrast the clinical significance of portal venous gas in neonates with necrotizing enterocolitis versus adults, and list the classic signs of pneumoperitoneum on a supine neonatal radiograph.
In that case, in adults, portal venous gas is an ominous sign associated with bowel ischemia and carrying a very high mortality rate, often indicating a premorbid state. In neonates with necrotizing enterocolitis, portal venous gas can occur transiently and does not carry the same universally grave prognosis or represent an absolute indication for surgery. On a supine neonatal radiograph, pneumoperitoneum can present as the football sign, where free air forms a large oval lucency in the central abdomen, and the Rigler sign, where free air outlines both the inner mucosal and outer serosal borders of the bowel wall, as seen on the second film.
Explain the significance of the peritoneal calcifications shown in the second radiograph and comment on the use of contrast studies in these patients.
Well, the second radiograph demonstrates flecks of peritoneal calcification, primarily over the inferior liver tip, alongside a positive Rigler sign. These calcifications confirm antenatal meconium peritonitis, indicating that bowel perforation occurred in utero, allowing meconium to spill and calcify in the sterile peritoneal cavity. If a contrast study is required to evaluate for distal bowel obstruction, barium is absolutely contraindicated due to the risk of severe barium peritonitis in the setting of potential perforation. Instead, water-soluble contrast must be used.
How would you manage this patient as a radiologist?
Okay. As a radiologist, I would recommend comparing these radiographs with prior films to assess the progression of bowel dilatation or pneumatosis. I would suggest checking for portal venous gas and evaluating all catheter positions. I would recommend immediate pediatric surgical consultation, as the presence of pneumoperitoneum is an absolute indication for emergency surgical intervention, such as exploratory laparotomy or peritoneal drain placement. Finally, I would document the findings, check for signs of ongoing ischemia, and immediately communicate the bowel perforation directly to the neonatal intensive care and surgical teams.